Hello tout le monde. Je vous laisse prendre place pour qu'on puisse continuer le symposium. Bitte Platz nehmen, so können wir weitermachen. Nur zuerst eine Information. Ihr könnt auf Slido-Plattform einfach ihr Feedback lassen. Vous pouvez laisser une petite information, vous pouvez laisser sur le Slido un petit feedback du symposium, si jamais. Voilà, on va poursuivre. Ich habe die Pleasure Dr. Eamonn Delahunt vorzustellen. He's a professor at the University College of Dublin. He's a nationally and internationally recognized sport PT. He's author and co-author of more as 150 peer-reviewed articles. It's an incredible number of scientific papers. His talk deals about update in the ankle problematic. Dear Eamonn, nice to have you here, and the stage is yours.
Well, good afternoon, everybody. It's a real pleasure to be here, and a sincere thank you to the Swiss Sports Physiotherapy Association for the generous invitation and the excellent hospitality. I've really enjoyed the conference thus far. In fact, earlier on, I just just sent a message to my wife saying, "Yeah, I'm learning lots." So it's a nice place to be here for a full day of learning. I want to talk about implementing the 2019 model of chronic ankle instability into clinical practice. So, lateral ankle sprains, they're often regarded as a simple injury that will heal quickly and without any need for therapeutic intervention. And as a result of this, colloquial terms such as a twisted ankle or a rolled ankle are commonly used to describe an acute lateral ankle sprain injury. I'd like to ask the question now, can we really consider a lateral ankle sprain as a simple injury that will heal quickly without any need for therapeutic intervention? Well, I would like to suggest no. And the reason for this is perhaps trifold. Lateral ankle sprains have the highest recurrence rate of any lower limb ligament injury. 40% of individuals who sustain a first ever lateral ankle sprain will go on to develop chronic ankle instability. And we know that there's an established link between ankle injury occurrence and the development of post-traumatic ankle joint osteoarthritis. This was a prospective study that we published in 2016 in American Journal of Sports Medicine. And we recruited 82 individuals who presented to a university-affiliated emergency department with an ankle sprain injury and who were subsequently diagnosed as having a first ever lateral ankle sprain injury. We tested them on a series of parameters within 2 weeks of their injury, 6 months post their injury, and 12 months post-injury. We utilized what we call the PCL model, so the patient, clinician, and laboratory model. We looked at patient-oriented outcome measures, clinician-oriented outcome measures, and laboratory-oriented outcome measures. And at the 1 year time point, we dichotomized them into two groups, those who developed chronic ankle instability and those who didn't. And what we found was that 40% of individuals who incur a first ever lateral ankle sprain injury will go on to develop chronic ankle instability. So I would suggest that that is not an optimal statistic. So we need to explore why that might be the case. But an important question is, what happens if an individual does not receive any therapeutic intervention following their first ever lateral ankle sprain injury? And this was the question that Tricia Hubbard-Turner sought to answer in her article published in the Journal of Athletic Training in 2019. She recruited 175 individuals with chronic ankle instability, and one of the primary questions that she asked them was, following your first ever ankle sprain injury, did you seek or receive medical intervention? Alarmingly, 64% of those 175 individuals with established chronic ankle instability never received medical attention or therapeutic intervention following their first ever ankle sprain injury. And why might that be important? Well, when we look at some outcome measures, so the FAM is the foot and ankle ability measure. It has two subscales. It has the activities of daily living subscale, and it has the sports subscale. So if we can see here, the maximum score on the FAM ADL is 100%. We see a difference between the two groups, those who received treatment and those who didn't. 89% versus 81%. So that was a statistically significant difference, but more importantly, it was a clinically meaningful difference, meaning that that difference of 8% exceeded the threshold for a minimum clinically important difference score. When we look at the FAM, so this is the FAM, ADL score is 21 questions. Maximum score on each question is 4, so we multiply 21 by 4, gives us 84 is the maximum potential score. The raw score, so what the individual scores, is divided by 84 and multiplied by 100 to give you your overall percentage score. If we look at the data from the sports subscale, again, we see a difference between the two groups, 81% versus 72%, whereby the individuals who never received treatment or medical intervention following their first ever ankle sprain injury had a worse outcome on the FAM sports subscale score. Again, that exceeded the minimum clinically important difference for that particular patient-reported outcome measures questionnaire. This is the FAM sports subscale. It has 8 questions. Again, 8 by 4 gives you 32. That's the maximum score that you can achieve. The raw score is then expressed as a percentage of the maximum potential score. What I would like to suggest to you is that you really have a detailed look at the domains and at the questions on the FAM sports subscale. So because of your foot and ankle problem, how much difficulty do you have jumping, landing, starting and stopping? And what I would suggest is that you use the FAM sports subscale to really sharpen the focus of your therapeutic lens or your rehabilitation lens. And what that I mean by that is, if someone was reporting extreme difficulty during deceleration or acceleration, it's important that you actually deconstruct that difficulty. So have a look at what are the constituent movement components associated with that activity that they are having difficulty with. Then what you can do is start to identify the associated impairments with that particular deficiency in movement profile, and then you start to manage the impairments in a structured, scaffolded way. Also, looking at the number of reported or self-reported giving way or self-reported recurrent ankle sprains, there was 4.7 in the non-treatment group versus 1.9 in the treatment group, and then giving way episodes per month, a higher number of giving way episodes per month in the non-treatment group. And we know that chronic ankle instability is characterized by 3 essential elements. It's characterized by an individual reporting a feeling that their ankle joint is unstable. They also report episodes of giving way of the ankle joint. So what does that mean? It actually means that they go into an inverted and internally rotated position of the ankle joint, but it does not produce any clinical symptoms. There's no pain, there's no swelling, and they can continue on with the activity that they were doing. And the most important one, the final one of the 3, is that they have a history of repeated ankle sprains. So we know that there's a well-established link between the occurrence of lateral ankle sprain injury and the development of post-traumatic ankle joint osteoarthritis. And this is a nice model published by Eric Wickstrom and colleagues back in 2013, and it illustrates that there's a mechanical component and then there's a sensory motor component. So I just want to talk through each of these in a little bit of detail. The main function of ligaments, as we know, is really to guide joint range of motion. And what ligaments do is they maintain joint range of motion within the accepted physiological range of motion for that particular joint of interest. When someone sprains their ligament, there's structural damage to that ligament. What happens is the structural properties, the tensile properties of the ligament change. You get a change in the instantaneous center of rotation of the joint, and as a result, you get abnormal loading of that joint, and that can precipitate the development of post-traumatic ankle joint osteoarthritis. If we look at the somatosensory system, following ankle joint injury, and in particular lateral ankle sprains, you're going to get damage to cutaneous mechanoreceptors, you're going to get damage to musculotendinous mechanoreceptors, and you're going to get damage to articular mechanoreceptors. What happens is we get the disruption in the flow of afferent impulses into the central nervous system. That has the effect of interrupting the flow of efferent outputs to the lower limb muscles. And as a result of this alteration in afferent-efferent balance, you get a change in the magnitude and timing of muscle activation. That can lead to altered movement profiles. Those altered movement profiles can then lead to altered joint loading, and that can precipitate the onset of post-traumatic ankle joint osteoarthritis. So we need to ask the question, why do 40% of individuals who incur a first ever lateral ankle sprain injury go on to develop chronic ankle instability? There's potentially, for me, 3 answers. Well, what happens when an individual presents to the emergency department with a simple ankle sprain? Well, the emphasis is really on a passive approach. What the emergency medicine physicians or the advanced nurse practitioners, all they're particularly interested in is ruling in or out whether the individual has a foot or ankle fracture. So the implication or the implementation of the modified Ottawa ankle rules. Once a fracture of the foot or ankle is ruled out, the priority shifts mainly to educating the patient on how to control his or her inflammatory symptoms. So rest, ice, compression, elevation, non-steroidal anti-inflammatories are often advised. However, here's the problem. Discharge criteria are vague, and also information regarding injury prognosis are often vague. What happens when an amateur athlete sustains a simple ankle sprain? So these are data from a nice study published by Jennifer Medina McKean and colleagues in Journal of Science and Medicine and Sport. And what it did was it charted the return to play probabilities of US high school athletes who incurred a first ever ankle sprain or who incurred a recurrent ankle sprain. And what we see in the table here is quite alarming. Okay? Individuals, 163 of them, sustained a first ever ankle sprain. And what we look at here is 95% of them were returned to sport within 10 days following their injury. If we look at individuals who incurred a recurrent ankle sprain, again, 94% returning to sport within 10 days following injury. Now, these data contrast with that of the highest elite professional sports level in Europe. So we have data from the UEFA Champions League injury surveillance study. And if we look at this, what it will show is that the mean time to return to sport for your Premier League player, for your Serie A player, is 15 days, with a median time to return to sport of 8 days, meaning that 50% of people will return in quicker than 8 days, but 50% of people won't return until after 8 days. So here we have the highest level of therapeutic care, and they're not returning to sport for 15 days. Where we go back to the American data here, 95% of the kids who are spraining their ankles are returning within 10 days post-injury. So what might explain that? Well, it's probably explained by the tape and play culture. And what we see with the tape and play culture is a complete disregard for physiological healing processes, okay? And we see a disregard for the acknowledgement of the need for therapeutic intervention post-injury. The other thing that could contribute to this problem of chronic ankle instability is physiotherapists' understandings, or actually, I'll re-clarify that, misunderstandings of the factors contributing to the development of chronic ankle instability. So this is a paper that myself and Fergal Kieran published back in 2010 in Athletic Training and Sports Healthcare, a small journal. What we wanted to do was really to use this model to inform our question. Just a hands up quickly, who in the audience has ever seen this model? Okay, so Mario, can you stand up there and I'll ask the question again and you can confirm to me whether it's a high proportion or low proportion of people here. So again, hands up, who has seen that model? So what would you reckon? Quite low? Yeah, I think so. So this is a seminal article. For anybody who is interested in ankle joint injuries, you should read this. It was published in 2002 in Journal of Athletic Training. It's open access, and it was by Professor Jay Hurtle from University of Virginia. And what he does is he outlines the mechanical and functional insufficiencies that contribute to the development of chronic ankle instability. Now, what our question is if physiotherapists, in their role in managing CAI, are to adhere to the principles of evidence-based practice, it is important that they are fully aware of the insufficiencies that are associated with chronic ankle instability. Because if you are not aware of those insufficiencies, both the mechanical insufficiencies and the functional insufficiencies, how can you develop a scaffolded, structured, impairment-based treatment model? When we look at the data, what we can see is a very poor understanding of the factors that associate with chronic ankle instability. So we here see that only 50% of the respondents said that impairments in strength is associated with the development of chronic ankle instability. Very few were able to mention postural control or neuromuscular control. And when we go to the mechanical insufficiencies, we see a much lesser understanding of them. Now, the problem is, okay, I'll go back to this. Mario said less than 1% of people in the audience know this model. There's a new model based on intervening research, and it looks a little bit more complicated than the old model. So this is what we see. Okay? So what I want to do now is actually have a look at some of the domains in this model and illustrate to you what you can do in order to address some of these impairments. And I'm going to concentrate on those impairments that are very easy to address from a clinical perspective and that will guarantee you good outcomes. So pathological laxity is the loss of structural integrity of the lateral ankle ligaments. It results in abnormal talocrural joint motion and subtalar joint motion. And this is what we classically refer to as mechanical instability. Let me go back. So on the right-hand side, I'm performing an anterior drawer test on an ankle joint. What you will notice is the appearance of this sulcus sign. That sulcus sign suggests that the anterior talofibular ligament in that athlete is completely ruptured. When we look at the data around the clinometric properties of the anterior drawer test, again, we see it has high sensitivity and high specificity. So what the anterior talofibular ligament does is it prevents anterior translation of the talus within the ankle joint mortise, but it also prevents internal rotation and inversion of the talus within the ankle joint mortise. So if someone has mechanical instability, one of the things that we need to engage in a discussion with them is the use of prophylactic supports. So in 2017, we published a systematic review of systematic reviews in British Journal of Sports Medicine. And what this forest plot here shows you is the studies that looked at prophylactic ankle joint supports in the form of taping or bracing for the prevention of recurrent injuries. So effectively, secondary injury prevention. Not primary injury prevention, but secondary injury prevention. What we can see here is the effect size is very much situated in favor of external support. So individuals who incurred a lateral ankle sprain, and if they prophylactically then use an external support, they have 0.4 times the odds of sustaining a lateral ankle sprain, a recurrent sprain, compared to those who don't use prophylactic support. And what we found is that there's strong evidence supporting the use of external support for reducing injury incidence and improving self-reported function. And that's quite important, is improving self-reported function. There's no point in improving someone's mechanical instability if that intervention is not translating into an improvement in that individual's self-reported function. What we also see is that there's moderate evidence suggesting that bracing may be superior for self-reported function in comparison to taping. So there's been 2 big randomized controlled trials from the US with over 1,000 participants in each trial, and they were undertaken by Tim McGuine and colleagues. I think it comes from American football and basketball, and in those randomized controlled trials, they were the 2 braces that they used. Again, depends on where you're geographically situated in terms of what type of brace you use, but in general, the recommendation is the utilization of some type of semi-rigid brace. One of the taping techniques that can be quite beneficial for limiting rear foot instability and reducing range of motion and velocity of inversion is this subtalar sling technique. So effectively what you do is you start at the head of the first metatarsal, you come across to the 5th metatarsal in a 45-degree angle, you come up over the lateral malleolus around the Achilles, and you finish off on the front aspect of the tibia. So just anecdotally, that seems to be very beneficial for individuals with chronic ankle instability, and particularly limits that inversion and internal rotation, so both the magnitude of that and also the velocity of that. Arthrokinematic restrictions is something that we need to address from a clinical perspective as well. So in contrast to pathological laxity, arthrokinematic restrictions refer to a reduction in joint range of motion. And in particular, in individuals with chronic ankle instability, they seem to be characterized by 2 arthrokinematic restrictions: an anterior displaced talus and an anteriorly displaced fibula. So the problem with an anterior displaced talus is that that's going to limit your dorsiflexion range of motion. And we know that in order to have proper dorsiflexion, the talus needs to glide posteriorly and rotate posteriorly to bring you into that closed pack, safe position of the ankle joint. Also, an anterior displaced fibula, what that will do is it shifts the origin of the ATFL slightly forward. And as a consequence of that, the ankle can go into a higher degree or a greater magnitude of inversion and internal rotation before the ligament becomes taut. So effectively, you get a greater internal rotation and inversion, and we know that that's the mechanism of injury. Osteokinematic restrictions refer to changes in musculotendinous structures that are going to limit joint range of motion. So one of the things that we can do in clinical practice is to implement the weight-bearing lunge test to assess whether someone has a restriction in dorsiflexion range of motion. If they have a restriction in dorsiflexion range of motion, we need to decide whether it's primarily mediated by an arthrokinematic restriction or an osteokinematic restriction. My suggestion would be is that in that situation, your outcome measure is the distance between the big toe to the wall, okay, your outcome measure for your weight-bearing lunge test. Apply some joint mobilizations in this situation. If that improves the dorsiflexion range of motion at the ankle joint, well, we're suggesting that it's an arthrokinematic restriction and that we can use therapeutic intervention in the form of joint mobilizations to improve dorsiflexion range of motion. So a systematic review and meta-analysis published a couple of years ago in Journal of Athletic Training suggests that mobilizations with movement, okay, your traditional Mulligan mobilizations or Maitland mobilizations may moderately improve dorsiflexion range of motion and dynamic postural control in individuals with ankle instability, and there seems to be a higher weighting towards Maitland or Mulligan mobilizations, that classic dorsiflexion mobilization with movement. So I would be a big proponent of utilizing that type of manual therapy to improve dorsiflexion range of motion. The reason for that is dorsiflexion range of motion has implications on landing mechanics. Okay? And when do individuals sustain an ankle sprain? It's predominantly when they're transitioning from a dynamic to a static position. So they're in flight and they come to a sudden landing, okay? Either in a vertical trajectory, a medial-lateral trajectory, or a horizontal trajectory. Thinking about static and dynamic postural balance, I think you can really implement some simple things to have some good outcomes. So one of the one of the assessments that I would be a proponent of is implementing the balance error scoring system. So effectively, there are 3 different stances that are performed under 2 environmental conditions. So we have double leg stance, tandem stance, and single leg stance. And each of those are performed on either a firm surface or a foam surface. You count the number of errors that the individual makes during the performance of the test. So effectively what it is, I'm standing here with my hands on my hips in double leg stance. Eamonn, 3, 2, 1, close your eyes, and I balance as quietly as I can. You, as the clinician, are going to count up the number of errors that the individual makes. Each one of them counts for 1 point. However, if an individual makes 2, 3, 4, 5 errors simultaneously, it's only regarded as 1 point. And the maximum score that an individual achieves is 10, meaning that they've basically failed the test. A score of 0 is a perfect test, whereas a score of 10 means that they failed the test. So this just gives you a look at what's happening at the ankle joint on the single leg stance on the foam surface. We can see a lot of activation, primarily from an ankle joint strategy of postural balance. These are some real data. So just take a minute to assimilate what this means and how we might interpret this and how we could use this to inform a simple static postural balance program. So player A was assessed on the balance error scoring system. Double leg stance on the firm surface, no errors were made. Tandem stance on firm surface, 2 errors. 5 errors, single leg stance on firm surface. Double leg stance, 2. Tandem stance, foam surface, 5. And single leg stance on the foam surface, 10. So no errors were made by player A when completing the double leg stance task on the firm surface. Hence, this task will not challenge the sensory motor system, and its incorporation as part of a rehabilitation program would be completely redundant. Why? The postural balance system learns when it is challenged. So that exercise there represents no challenge to this patient at this time point during his or her injury, and as a result should not be used as part of your clinical intervention. Player A made 2 errors whilst completing the tandem stance on firm surface task and the double leg stance on the foam surface task. This low number of errors would suggest that these tasks should only constitute a minority component of your rehabilitation program, whereas the ones that were associated with 5 errors here and here, they're appropriately challenging to the sensory motor system. They're not so easy that the individual can complete them without any errors, but they're not so hard that the individual can't complete them at all. Whereas if we look at the single leg stance on the foam surface, the individual scored 10, maximum number of errors. So that would suggest that at this time point during their injury, that exercise is not appropriate to include as part of the rehabilitation. So what you can do now is start to construct a static postural balance program based on an objectification of an individual's performance on the balance error scoring system. Other things to concentrate on would be the concept of limb symmetry. So we can have limb symmetry or look at a symmetry index between tandem stance on the firm surface. So my right leg is injured. In the test, the injured leg always goes to the back during testing because in tandem stance, you tend to transfer weight onto your posterior leg. I could change it around so that my non-injured leg is at the back, and I can look at the symmetry between performance on both sides. The same for single leg balance as well. So that can give you an indication of how well your intervention is making a difference from that perspective. What happens following an acute lateral ankle sprain injury? Well, this is an article that we published some time ago in Clinical Biomechanics. And what we found is that during the acute and subacute phases of injury, an individual will have impaired postural balance on their injured side, but also on their non-injured side. So it suggests to us that during the acute phases of injury, you should be concentrating not only on the injured side, but also on the uninjured side as part of your therapeutic intervention. And again, that refers to this concept of the afferent input into the central nervous system and the efferent output. The other thing that you should concentrate on is trying to unfreeze the foot. So when we consider postural balance control, there are two mechanisms or two strategies of control. There's an ankle strategy and there's a hip strategy. And what we find is that in the acute and subacute phases of injury, individuals following a lateral ankle sprain will have a depression or impairment in their ankle strategy of postural control. And what they do is they shift to a more inefficient hip strategy of postural control. So what we need to do during that acute and subacute phase of injury is to try and unlock the foot. And I think when we look at the foot, we need to balance its function as a rigid lever versus a mobile adapter. And in particular, what we tend to see is the development of rigidity across the midfoot. And a lot of time during the acute and subacute phase of injury is spent doing mobilizations on the midfoot, particularly the calcaneocuboid joint and across the mobility of the cuneiforms. So trying to decrease the hypomobility through the midfoot will allow the ankle and foot to unlock and lock. And we know that during gait cycle, the foot has to adopt a rigid lever for push off, but it also has to impact or reduce ground reaction forces during heel strike and then into stance. And then the other thing that you need to ensure that you're working on is if someone is adopting a hip strategy, that they actually have efficient and strong hips in order to control pelvic position and to neutralize or diminish that reliance on hip strategy of postural control. So moving on now to think about dynamic postural balance. I'm sure everybody is aware of the STAR excursion balance test. We utilize it as an outcome measure to assess dynamic postural balance. So this is correct performance of the SEBT. Okay. Goes from a double limb stance position onto the test leg, reaches forward along a tape as far as he can, trying to go soft through the hips, knee, and ankle, and returns to a stable position. Okay? It's really important that you instruct an individual on how to perform this test. That's not an adequate SEBT performance, this type of stuff. Okay, we get the average of your 3 measures there. It doesn't challenge the postural control system in any way. Okay, so correct performance of these is quite important. Here we have the posterior medial reach direction. Okay, you can see it's a controlled movement, reaching, looking where he's going, a light touch, and returns to the stance position. And then we have the posterior lateral reach direction. Okay, light touch on the tape, returns to the double limb stance position. Typically, what we like to see is over 100% of leg length in the posterior medial and posterior lateral reach direction, and over 60% of leg length in the anterior reach direction. Your reach distance, how do you quantify someone's performance? Well, you divide the distance that they reach by the leg length and multiply by 100. That's your reach distance in each direction, but you can also get a composite or composite score where you sum the distance reached in the anterior direction, the distance reached in the posterior medial reach direction, the distance reached in the posterior lateral direction. So there's 3. You divide by 3 times leg length and multiply by 100 to get your composite score. So how can we affect dynamic postural balance? So this was a nice randomized control trial published in Medicine and Science and Sports and Exercise back in 2010, and certainly would advocate that you have a look at this, because when we look at the outcome measures that they used self-reported function and they used the star excursion balance test. And when we look at the effect sizes associated with the improvements, we see that the effect sizes are large and clinically meaningful. So what they did was they set up a grid where you have a start position and you hop forward 18 inches and hop back to the start position. That can be then progressed to increased distances. But what does that actually look like? Here we have Carl again, hopping 18 inches forwards and back. Okay. Now, what you can do is quantify an individual's performance on this test by looking at, do they touch down with the opposite limb? Have they excessive trunk movement? Do they remove their hands from their hips during hands-on-hips activities? Do they brace the non-stance leg against the stance limb, or do they miss the target? So you can add some type of quantification to this particular drill. Next one will show a hop and reach. So effectively what he's doing, he's hopping in a lateral direction, stabilizes, reaches back to the start position. So effectively what you're implementing there is an element of that star excursion balance test again, where you're reaching in a controlled manner to a target and hopping back. Again, same errors that are quantified during the hop stabilization. When we look at the data from this trial, what we have is the FADI. So the FADI is the Foot and Ankle Disability Index. I mentioned the FAM earlier on, which is the Foot and Ankle Ability Measure. The FADI was the precursor of the FAM. Okay, so it was just an older version of the FAM. What we can see is that the balance training group improved their FADI from 85 to 93 and their FADI sport from 70 to 85, and there was no difference or no change in the control group. When we look at the group effect and when we look at the time effect, we see that there are large effect sizes. So these implementation of this dynamic postural balance training program has a real clinically meaningful effect on someone's FADI and FADI sport outcome measure scores. When we look at the data from the star excursion balance test, interestingly, there was no improvement in anterior reach distance. However, there was an improvement in posterior medial reach distance and posterior lateral reach distance. And again, when we look at the effect sizes from a group perspective and a time perspective, we see large effect sizes. So moving on then to the concept of diminished somatosensation. So several domains of somatosensation need to be have been noted to be impaired in individuals with CAI. And they're joint position sense, threshold to detection of movement, force sense, and cutaneous sensation. And what they do is they interact together to result in the development of aberrant movement profiles. So what we say is that injuries corrupt the sensory motor accuracy of lower limb motor control during movement tasks. This is an interesting study published by Daniel Fong and colleagues in American Journal of Sports Medicine. And they used an engineering technique called model-based image matching to reconstruct the 3D skeletal kinematics of ankle sprain injury events. So this plays very, very slowly, but this is a famous one in the world of ankle joint injuries. You see he's lunging in to retrieve a drop shot, and we can see the magnitude of inversion and internal rotation of the ankle joint there. They reported upon 5 cases in that article. And what we see is that ankle sprains, the characteristic injury feature is inversion and internal rotation, irrespective of sagittal plane motion. So a lateral ankle sprain can occur in dorsiflexion. It's not just a plantar flexion, internal rotation, inversion injury, and that's something that we need to consider. When we look at the data, so the reconstructed three-dimensional kinematics, what we have here is time along the x-axis. So 0 represents contact with the ground, and what we have is inversion in degrees. Interestingly, in 4 of the 5 cases, the ankle joint was already in close to 20 degrees of inversion upon contact with the ground. So why might that be important? Well, there's a biomechanical study published by Wright and colleagues suggesting that if you land with an already inverted position of the ankle joint, it heightens your risk of sustaining an inversion trauma. Why? Because the orientation of the ground reaction force is changed, and an inverted position increases the external inversion torque acting on the ankle joint, so it's much easier to go over on your ankle. So what can we do from a therapeutic perspective? Where you will also get positive outcomes is if you place an emphasis on re-education of hopping and landing strategies. Okay? And when we think about scaffolding and structuring our hopping and landing activities as part of our rehabilitation, we need to think about the 3 different force vectors. So the ability to control vertical ground reaction force, the ability to control anterior-posterior ground reaction force, and the ability to control medial-lateral ground reaction force. So that's what I would like to suggest to you is, when you're thinking about constructing your hopping and landing program, think about how you load in the vertical plane, how you load in the anterior-posterior plane, and how you load in the medial-lateral plane. So, this is a modified version of the Haddon matrix. And the event in this instance is a lateral ankle sprain injury. So we, as therapists or clinicians, can intervene prior to an event happening. And that's the focus on primary injury prevention. And we can focus our efforts on post-event, so trying to reduce recurrent injuries. And when we think about where we can intervene, so we can intervene at the athlete level, we can intervene at an equipment level, and we can intervene at a rules and regulations level. So anybody who has an interest in soccer or football will know that it's now an automatic red card if you tackle off the ground above ball level. That has resulted in a reduction in the number of ankle sprains and a reduction in the number of tibia and fibula fractures. So that's how you would intervene at a rules and regulations level. How might we intervene at an equipment level? So I was lucky enough to be involved in this pilot randomized controlled trial with 510 participants. Okay, so the biggest pilot trial ever. So effectively, there's a thing that you can apply to the outside of the ankle, and this is particularly for athletes who are involved in court sports. So the likes of handball, the likes of volleyball. So with the shoe surface interaction, there's a friction coefficient there. If the friction coefficient is too high, it can cause the ankle joint to go into an inverted position. So what this company came up with, Spraino, was to develop a patch that's applied to the outside of the ankle joint. So let me just go back here. So that's what happens if the coefficient of friction is too high. So this patch is placed onto the outside of the rear foot and the forefoot. What it does is it allows the individual to slide out of that inverted position. Okay? So this has been tested from a biomechanical perspective. And when we look at what happens on ground reaction force, it reorients the ground reaction force and allows the individual to slide out of that potentially injurious mechanism. But what we needed to do was to test that in a randomized controlled trial. So there was two groups. There was the group who received the allocated intervention, and what they were asked to do was to apply the Sprano patches for every training session and for every competitive match that they played in. And then the control group just did as what they usually would do. So we had good follow-up, and this is the infographic that was produced as a result of this study published in British Journal of Sports Medicine. So I just want to draw your attention to two of the graphs here. Individuals with chronic ankle instability tend to have a fear that they'll sprain their ankle joint. That's one of the key characteristic features. They feel that their ankle joint is unstable, and they have a fear that they're going to sprain their ankle joint. So at baseline, the two groups were the same. And then at the end of the trial, we saw that there was a statistically significant difference in terms of fear of spraining between the two groups, whereby the Sprano group had less fear of spraining their ankle joint. When we look at pain, they had similar levels of pain at baseline, and then at follow-up, the group using Sprano reported less pain in their ankle during participation in training and during participation in matches. Did we notice any difference from an epidemiological perspective? Well, yes, we did. From an injury incidence perspective, the main effect was by reducing the injury incidence of non-contact ankle sprains in the Sprano group, and that difference was statistically significant. So I'm going to finish off by saying here now, what I've just touched on is the concept of chronic ankle instability. I've oriented you towards the 2002 model published by Jay Hertel. Back in 2019, before COVID hit, in Amsterdam, we had the International Ankle Consortium, and Jay Hertel was giving a keynote lecture. And what he said is, I never want to see the 2002 model cited in papers again. Just shift your focus to the 2019 model, and that's the 2019 model. I've shown you how to potentially assess and treat pathological laxity. I've suggested to you that you need to think about arthrokinematic and osteokinematic restrictions. I've shown you how that diminished somatosensation can have an effect on movement profiles. And I've also shown you how to potentially assess for static postural balance impairments and dynamic postural balance impairments. If we move towards an impairment-based model of treatment, I'm really sure that what we will do is we'll have increased physical activity in these individuals. We'll have less kinesiophobia. We'll have improved self-reported function, we'll have less pain, and we'll have improved health-related quality of life. So, thank you for your attention.
Thank you very much for this very interesting presentation. Are there questions from the audience?
But you're all awake, so that's good news. So, no question?
Yeah.
Yeah. One on the front.
Go on, I'll hear you. And we can relay the question. We're not too far.
J'ai souvenir que dans la...
I studied French for my back, so I can kind of pick up a little bit of pieces.
Why we still using anterior direction in the SEP test? Because I remember that... Voilà. I remember that there are more studies that they show there is not a specific way to test. I don't know. We starting with posterior, medial, and lateral, but I think that researchers tell us that are more specific only the medial and not lateral or anterior direction. Why we still using this? And you also show some data that you don't increase your anterior distance after training.
Yeah, so the original utilization of that is based on sort of an understanding of the statistics of the whole test. So there are 8 different reach directions. So some analysis was undertaken to determine from a principal component perspective what were the 3 most representative directions. And they found that the combination of the anterior, posterior medial, and posterior lateral was most representative of total performance on all 8 directions. So that's where that classically came from. When we look at some of the data as well, we see that performance in the anterior direction is highly correlated with static postural balance as well. But even though when we look at from a dynamic perspective, there was no change in the anterior direction, which seems a little bit odd to me as well. Yeah.
Another question?
Thank you very much for the brilliant presentation. It was very interesting. I was just wondering what your take is on perineal muscle strands in this context. Is it important, or do we know anything about it, and how can you measure it?
Yeah, good question. So you saw that I didn't include muscle strength as something, as a key element to concentrate on. The reason for that is we don't have an awful lot of good clinical studies looking at muscle strength. When we actually look at extracting the information, when we go to sort of systematic review and meta-analysis level, what we see is that the most, or the biggest effect, estimate, size, or improvement is through balance training and through hopping and landing. And there's less effect by just concentrating on an isolated muscle strengthening program. Now, that's not to say that we shouldn't. Of course, following joint injury, as was articulated earlier on by Professor Schneider-Mackler, we get arterogenic muscle inhibition. So by principle, we should be working on muscle strength. When it comes to the assessment of peroneal strength, inversion or inverters, everters, it's hard to do from an isokinetic perspective. Okay, we also have to think about the lever arm of those muscles as well, and how we normalize the data relative to the lever arm. All we know really is that when we test from an isometric perspective, that you typically will have a ratio of inverter to everter strength of 1:1. But certainly, I'm not suggesting that you shouldn't include it as part of your rehabilitation program. Yes, you should. Okay, so in a 30-minute talk, you're constrained by what you can talk about. So in terms of level of importance, what I talked about there, that would be kind of my scaling factor, and then the next one would be concentrating on muscle strength.
Thank you very much.
Thank you.